Hey everybody, welcome to this week's episode of Whiskey Neat, Spirited Conversations with Interesting People. I am your host, Christopher Hart, and today was a first in many ways. And by many ways, I mean one specific way. Today, not only did we not drink at all, surprisingly, no drinks were had, but also today was a different type of conversation. Many people who are fans of this show and are part of the online community for whiskey are very close to many people and have at least interacted with many people that might be indicating some concerning behavior. So I thought it would be really fascinating if we got in two very important people that deal with alcohol abuse and discuss alcohol abuse. So today I'm joined by Dr. Christopher Verrico and Dr. Daryl Shorter, both assistant professors of psychiatry at the Baylor College of Medicine. And they're currently working on a study that involves alcohol abuse. And I won't go into too much here. I'll leave it for the actual episode. But these guys have a deep connection with all sorts of abuse, whether it be opioid, drug abuse, alcohol abuse, and are working on a study to kind of specifically, the study, its intention is to find a medicine that's better than what's currently out there that would help people, specifically veterans, with alcohol abuse. And it was a fascinating conversation for me. I thoroughly enjoyed it. I'm a complete idiot, but I felt like I could keep up with most of what was being said. And I'll tell you, I wish this episode was 2 hours long. I am going to have them back on. We are going to continue this conversation, and I really feel like we hit the tip of the iceberg. So please rate and review us on iTunes, Google Play, the whole 9 yards. And this episode was brought to you today by Bunnahabhain. Bunnahabhain is our newest sponsor. They are now sponsoring us through 2020, by the way. We've got some new sponsors coming on the show, and Terlato Distel, they have been making fine spirits like Deanston, Tobermory, Leche, as you've, I'm sure, noticed astutely that we've been doing a lot with them the last couple of months, especially with our event. And we're big supporters of theirs, and they are a big supporter of us, and we really can't appreciate it enough. So without further ado, Dr. Christopher Verrico and Dr. Daryl Shorter with the Baylor College of Medicine. Cheers. So, thank you guys for being here.
Sure.
Chris,
happy to be here.
Yeah.
Hey.
Daryl.
Yeah, thank you.
Thanks so much for coming. It was so crazy. So I had this idea, my wife and I have been doing this for quite some time, drinking and visiting distilleries, and there are lots of podcasts out there in regards to whiskey and spirits and wine and beer and what have you. So it literally hit me like a lightning bolt a couple weeks ago. I bet there's some pretty smart people here in Houston that are working on something in regards to alcoholism and studies. So
There probably are.
within
We should meet them.
Yeah, within a very quick Google search, I found two. You guys were number one, the very top link. What's going on over at the Baylor? I've been having the hardest time saying Baylor Medicine of College. No, that's not right. Baylor College of Medicine. Something about that in order is tripping me up a little bit. And I haven't even started drinking yet.
Well, it'll just get harder for you.
You'd be surprised.
That's
that's actually why you guys are here today. So you guys, I want you guys to kind of tell me what's going on with, we do have a camera here, but I don't know if Jack said this, but we're talking to each other, but the camera's eavesdropping. So,
yeah.
What are you guys working on right now?
So currently we have a few studies that are going on. They're at different stages of development. And so the one study is what's called an alcohol interaction study. And so it's with a compound that has not been approved by the FDA or the Food and Drug Administration.
Sure.
And so before you can test any new compound as a treatment for alcohol use disorder, you have to make sure that it is not going to cause some interaction with the compound itself. And so the alcohol could affect how the drug impacts you, or the drug could affect how alcohol impacts you. And so it could make you more drunk, something like that. So we are currently conducting one of those phase 1 studies, as they're called. And we also have a phase 2 study going on. And that is, so it's already, it didn't need the alcohol interaction study to be done because it's a widely available FDA-approved medication already called zonisamide, which is used for epilepsy.
Okay. And somehow you can also use that for something in regards to alcohol?
Well, surprisingly, there's a drug called topiramate, which is FDA approved for seizures as well. And there's been a number of research studies that have shown that it helps people reduce their alcohol intake. And so the problem with...
As a side effect.
I guess it was a side effect initially. I'm not sure exactly what the rationale behind, the first study that was done. But there have been several done. And so they've shown that topiramate helps reduce drinking. And the problem with topiramate is it has a lot of side effects that people can't tolerate. And so we're taking a drug in the same class as an anti-epileptic drug and testing it because it's thought to have fewer side effects.
And we're hoping to basically help those who have alcohol consumption issues in which they drink too much or obviously an alcoholic. You're hoping to kind of curb that in what is essentially in a completely dumbed down version, an appetite suppressant.
No.
But for alcohol.
No. So it's not an appetite suppressant. It's for seizures.
Right. No, but I mean, like the side effect is that you don't consume as much. Like you don't feel the need to drink as much.
Right.
Right. So that's what I mean. It's like a completely dumb layman's like
a craving reduction.
Sure. Correct. Yeah. And that's what you're testing that idea to use it for that to that effect.
Yes.
And that's the only study you're working on, or are you working on more than one?
Well, so the first one is the alcohol interaction study.
Sure.
And it's a different drug altogether. And then the second study is further along in development. And so it's the outpatient trial. And so that study enrolls veterans who have PTSD. And PTSD is strongly associated with alcohol use among veterans. So,
I know a few.
Yeah.
It's quite common.
Yes, it is.
So let's start with the simple terms. What is the, and I'm sure it is, because this has come up before. What is defined as an alcoholic? What kind of key indicators or consumption numbers are we talking that would say, okay, you've got a problem? Even if it doesn't affect your life negatively, right? They've got that whole function.
So I think one of the first things to clarify for folks is that we have really tried in the medical field to get away from the term alcoholic. It's not really one that we use.
What do you use instead?
So I usually will refer to people as a person with an alcohol use disorder.
Okay. Alcohol use disorder.
Yeah. So we've gone through a number of different terms for how to define what problems with alcohol are. I mean, you probably have heard people talk about alcohol abuse, alcohol dependence.
Sure.
That's another one that was commonly used. And the mental health field has a book called the DSM, the Diagnostic and Statistical Manual, and it sort of is the Bible for mental health providers. It gives us the criteria for
determining that
for psychiatric conditions. Absolutely.
Right.
And so in our most recent version of the DSM-5, they created a category called substance use disorders. And the nomenclature now is that we refer to alcohol use disorder, tobacco use disorder, methamphetamine use disorder. Everything is referred
anyone
to
who's addicted to said substance.
Yes. Correct. And addiction has some
spectrum.
Or it's murky, I think, because of the way that people have kind of taken that term. You can be addicted to lots of things now. And so because there are so many different things that people could be addicted to, and people talk about I'm addicted to hair gel. I don't have hair, but I imagine I did.
I'm barely holding on as well, so we're there.
Hold on as long as you can.
I'm trying. I am trying.
Hold on. But because
this guy over here,
right, and he spikes it up.
I'm walking here. I hate him already.
I know. Well,
I get that a lot.
Yeah. You will continue because this is a beautiful head of hair that you will probably keep for forever. But because people can sort of among lay persons be addicted to lots of different kinds of things, I think we wanted to be more accurate in our descriptions of people that were struggling with addictive disorders. And so the most recent DSM really clarified what it means to have an alcohol use disorder. And we can just kind of riff on what that is. I think, generally speaking, the first thing I think about when I think about someone who's struggling with an alcohol use disorder is that they've developed a tolerance to drinking, meaning that the same amount of alcohol that may have worked for them when they first started drinking, that same amount doesn't work for them. It doesn't get them to where they want to go as much or as easily.
So throughout this discussion, I'm going to have a lot of counter questions.
Yeah, please.
To get you to expand on some things.
Sure, of course.
Just for the sake of trying to, like I'm an idiot, right? So just grasp as much as we can. So my first thing that popped in my head right now as you said that was, is there a case in which you can have alcohol use disorder and not function off a higher need for more? Meaning, what if you're drinking the same amount you've always drank and you still could have a problem?
Absolutely. So the way that the criteria work for the DSM, you do not have to have developed a tolerance in order to meet criteria for an alcohol use disorder.
Vice versa.
There are 11 different criteria. And if you meet 2 of the 11, you would be diagnosed as having an alcohol use disorder.
Whoa.
Mild alcohol use disorder.
Mild, but is mild is okay. So okay, whoa, I feel like I'm about to face some demons this podcast. No, so before we expand, let me ask this: Is there a possibility in which you can raise your tolerance but not have AUD?
Yeah.
Yes. Okay. If that is the only
indicator
criteria you meet.
Right. You start hitting 2 out of 11 seems like a real low bar to hit. Jack doesn't even drink and he hits 3 of them. So
but I think what we were trying to do, or what they were trying to do with the DSM, is to make sure that we caught all kinds of people that had problems.
We're humans. We're a spectrum
exactly
of things.
Right.
Almost everything we are diagnosed with is on a spectrum of severity.
True.
And we're these complicated little animals. So I totally get it. So let's start from the top, if we don't mind. What are the 11?
So tolerance is one.
Okay.
The next one is withdrawal. So if someone, when they stop drinking, they develop a characteristic syndrome, it can be anxiety, insomnia. Some people, when they go into withdrawal, it can be very severe for them. They can have withdrawal seizures. People probably have heard of DTs, the DTs.
Sure, the shakes.
Yep, the shakes, delirium tremens. So those qualify as symptoms of withdrawal. The one that I think is probably one of the cardinal symptoms of alcohol use disorder is when someone reports to me, when I'm seeing them clinically, that they have tried to cut down or control their use and they have been unsuccessful in doing so.
As someone who has no medical experience, but I watch a lot of House, I have often, that's usually been an indicator to me when someone decides they want to take a break. The fact that they've recognized I need to take a break is usually like a woof, because there's been times that I've been exhausted. I do a lot of drinking for work where I literally supposed to drink, and I give you a great example. Yesterday, I was filming it from 6 a.m. the wrap up on that thing we were talking about till noon. Then had meetings that went on till 9 p.m. I didn't want to drink anymore by 9. And when I ordered a beer at a restaurant, now it wasn't like tons of consumption. It was just an exhausting, long, menial day of like a pour here, a pour here. And I had my final meeting at 7:00. And when she showed up, we ordered a beer. I didn't even drink it. I just didn't want it. Now, there wasn't like a need to take a break. It was just like when you're drinking because you have to, it's
But I think when people are talking about we're talking about a pattern of behavior that people exhibit over at least a 12-month period. And so it's not just that someone tries one time and they're unsuccessful in cutting down or controlling their drinking. Right. It's really, I've developed a pattern of this where I'm like trying.
I've been trying to lose weight for a couple of years, and I'm stuck at this 10-pound mark, and I've got food use disorder.
You're not yet 40, are you?
No, I'm 31.
Yeah, okay, we'll keep living.
Eat up, buddy. So withdrawals, and they're having a hard time.
Yeah, so unsuccessful efforts at cutting down. So when people are spending more time trying to either obtain alcohol, more time drinking, or more time recovering from the effects of alcohol. That's another one. Sometimes people can experience an impact on...
Sorry, I'm going to try to write these down while we get this. So tolerance, withdrawal, what would be the next one?
So unsuccessful efforts at...
okay, I didn't know if that was tied to the withdrawal thing.
Yeah, so I'm going to have to write them down too.
Distinct, okay. And then what was the next one?
Increased time.
Okay, recovery, yeah.
And...
Problems with family?
Sure.
Role obligations.
Or, work.
Problems
like
with personal life. Okay.
When people drink in hazardous situations. So hazardous
driving
use.
a car.
Oh, sure.
Going swimming.
Wait, that's not... I'm just kidding. Hazardous use. All right.
Why am I blanking?
Continued drinking despite negative consequences.
That's great.
Okay. Yeah. So despite not learning from their mistakes in that regard,
your wife, yelling at you for drinking and being out
dinner
all
was
night,
cold. That's
things
her
like
fault,
that.
not mine. Despite negative consequences.
Drinking despite psychological or health problems. So when people continue to drink, if they know that I saw a guy...
Liver disease.
Yeah,
sure.
had liver disease and he continues to drink. And so that's one as well. Craving is one. So
it's funny. As you go down this list, I'm thinking of people I know who are guilty of some of these things. It's surprisingly easy. Yeah. Two things. So one thing, as I've been in this industry the past few years, I've learned that it's remarkably easy to blow over, right? And so when people don't realize what they think is normal, it's normal for me to go out and have 4 cocktails
and then drive home,
and they don't realize you're actually blowing over.
Way over.
And they'll preach responsible drinking, but they don't realize because they've never blown, right? So they don't realize how easy it is to blow over.
Yep.
The other thing I realize is, as you're naming them, the people I know that are guilty of some of these things.
It's very rare for most people who drink alcohol even casually not to have developed tolerance at some point.
Tolerance,
I mean, I know for myself that certainly when I first started drinking at whatever age that was, at 21.
Yeah. On the nose. Yeah.
It certainly more now.
Sure. So this is something that I've noticed some people I know that have developed a lower tolerance. Is that possible? Where you drink so much so often that you actually, it's almost like a reverse
tolerance.
Yeah. Like a reverse tolerance. I've known people that have had issues to drink, most people know some people that have had some sort of issue at some point or another. And I've seen them drink less and still kind of exhibit signs of drunken behavior.
Is it after a break, like after they stop drinking for a while and then they...
I never really picked... never really picked up on that. So we've got 3 left. What was the next one?
Craving.
Okay.
Craving. So one of the ways that I try to ascertain if someone's experiencing craving clinically is I ask
That's
them,
a good question because I have some questions on that specific one.
So one of the questions I ask is about what time of day do you start thinking about drinking?
Sure.
Or when people have experienced cravings, a lot of times they'll say that they can occur for them physically, they can occur for them mentally, and so they kind of will either start thinking about it or they'll get a feeling, a fluttering. Some people, like I've had some folks describe it as like I just feel it, kind of my skin almost tell me, and so all of that to me counts as craving.
So the inference or the implication I'm getting from what you're saying is it possible that what you're saying is that depending on the time of day, that craving wouldn't necessarily be a bad sign? Meaning, if they're getting cravings at the end of a 10-hour day, or for those stay-at-home moms who are about ready to kill all their kids, is that less of a worry that they're craving a glass of wine at 6 p.m. versus those who are craving at 10 a.m.?
So let me admit that people who get referred to see me usually have screened positive for some sort of alcohol problem.
Okay, sure.
So in my work, typically the folks that are seeing me have already been either diagnosed with alcohol use disorder or their primary care physician suspects strongly that they have alcohol use disorder. So that's how they end up seeing me. So my conversation with them, I think, is tailored a little differently than it might be for other clinicians who are just trying to figure out sort of, do you have a problem? Yes or no? And to what extent?
Because my other question to that would be shift worker, right? So I've worked in aviation as an aside to my day job or this other job that I do. And if I'm working, a 10-hour shift, I get off at 7 a.m., I go home, I have a burger and a beer. Drinking at 7 a.m. for most would think, and no, it's actually my.
But you take all of that into consideration as well when you're trying to determine the the extent to which someone might be experiencing cravings. You know, the thing.
Sorry, no. By the way, me pushing on these questions are not me trying to dismiss my own behavior.
No.
Just I just realized, but no, it's fine, right?
I'll be leaving my card when we're done. I mean, so
the fact that I walk in with a bag of 12 bottles, is that on this list?
Yeah, well,
I walk into a bag of whiskey.
We're leaving our card.
Okay, all right.
But I think that there are folks out there who really begin thinking about their first drink. You know, they say they work 9 to 5. They start thinking about their first drink at 9:30, and for them, it is a real struggle to get through the day until they can make it to 5:05, where they may have a bottle in the car waiting for them.
So it's not just the craving; it's also the stress-induced part of that. Like the fact that you are that dying for something and you're counting down the moments, that's a huge red flag.
Yes, for certain people, absolutely. Yeah.
Okay, so craving, 2 left.
Mm.
And if you don't remember off the bat, I still have plenty of questions about all the other ones.
Let me keep thinking.
2 of them. So let's say you've increased.
Giving up activities is one.
Like not
other
going anywhere.
pleasurable activities.
Sure.
Right.
I don't want to play football today. I'm going to stay here.
I'm not playing football today. I'm getting drunk on the couch and watching it. Yeah.
Sounds awesome.
Giving up activities.
Yeah. So then there's one more.
Sacrifice of time. Okay. So,
Continue to drink despite negative consequences, physical, mental. This is going to bother me.
It's okay. It's okay. Listen, to 12. Is forgetting one of them? Forgetfulness? No. So, and do you guys both drink? Do you guys, you don't consume at all? No.
When you
part
do
of being
this
an adult.
Right. Well, part of that is it. But I think what can happen for folks is that when you do this kind of work, you get really self-reflective about your relationship to all kinds of things.
That's why I would never date or marry a psychologist or a therapist, right? I feel like I'd be reading into everything.
There are lots of people who feel that way.
Yeah. So I totally get it. And this is not the same comparison, but I used to do wedding planning and take pictures. And
a lot of jobs.
This is when I was many moons ago.
This is over a decade. Were you taking pictures from a plane? You mentioned you had an aviation job also.
No. So
this is the psychiatrist. When I was
19, well, actually, I was much younger. When I was 16, I started doing wedding photography.
Okay,
and it got to the point that I couldn't stand going to weddings as a guest. I couldn't stand listening to the same, like they'd always hire a DJ who'd play the same 10 songs, and I would see a lot of the same DJs at the same weddings. And he when he's in his car alone, doesn't listen to anything. He hates music on the radio because he plays music constantly. He's tired of hearing Cotton Eye Joe, right? So it's the same typical bridal he rides in silence. And I would imagine if you spend your life reflecting on, or not reflecting, but diagnosing and helping and being a doctor and helping those who have issues with alcohol consumption, I would imagine it might be a bit of a turn off for you.
Yeah, I mean, I think what you see is the incredible destruction that can happen in people's lives as a result of it. And
you see some of that manifest in yourself sometimes too. I think
sure
that you can look at these criteria and say, "Hey, I am close to meeting that," or "I could see how this applies to me," and then you start to reconsider what you're doing and say, I need to back off.
Definitely.
And I think that's...
And I think that speaks to the major criteria. When someone notices, hey, I may be doing this a little bit more, drinking more than drinking more than is intended.
Yeah.
Okay.
Drinking more than is intended.
Is that the last one?
Mm-hmm.
All right.
Yeah.
So what's the difference between that one and increased time?
So one is so when you think about substance use disorders kind of more broadly, the time criteria is, I would say, separate from the consumption aspect, because I don't know, help me out here.
I can kind of, I'm thinking of
what was the time one?
So it's increased time preparing to use, using, or recovering from the effects of use. That's the time one.
Right.
And then the other one is
that was
using more than intended. It's an amount situation.
You say, I'm going out, I'm going to have one beer,
right?
But you have 3.
Yep, and it's 4 a.m.
and my wife's situation, even though you've done it in the same amount of time.
Yeah.
Sure.
Yeah, it's just the idea that I want to cut down, I'm going to limit myself, and then you fail to do that.
Yeah.
Okay, so 2 of those things is mild.
Yes.
Should you be worried, or should you just be cautious?
So that's a really good question. I think that, so I also have a conversation with people about the amount that they drink as well.
Sure,
So,
because 4 for women, 5 for men is considered a lot.
yes.
In one sitting.
In one sitting.
And if it's in a 2-hour period, it's considered binge drinking.
Oh wow. Okay.
Yeah.
This show's an hour long, so it's a 1 hour period. No, I'm just kidding. There's only been a few times. We actually had a couple of sports guys in here one episode, and we bring bottles that sponsors give us and stuff we want to taste through, but we don't the intention's not to drink everything available, and they took it as a little bit of a challenge. So they drank through all 6 offerings, but these weren't full pours. We're talking bites, little taste treats. So, and this was them, not me. So they should be worried. Mild. So I say alcohol use disorder. Is AUD replaced for that often? You
Yes.
guys say, okay. So in layman's terms, we would imagine old school that would be mild alcoholism.
Yes.
But you don't use it. Okay. So you could say someone's a mild alcoholic if they hit 2 to the 11.
Yep.
2 to 3.
Yep.
Okay. Now, there's an old saying or feeling that there's no cure for alcoholism and that you're always an alcoholic even when you haven't drank for 15 years, right?
Yeah.
Steve-O is 15 years sober. He would still be considered an alcoholic even though he has not drank in 15 years.
Yeah.
That's accurate. Is that the
That's the prevailing
mentality?
Yeah, that's
mentality
the
for
prevailing
sure.
one. Yeah.
Yeah.
So what's the difference then for someone who, let's say they hit 2 or 3 of these now, right? Still mild,
Mm-hmm.
and they just decide to stop. Like you said, you used to, you don't need more because you hit 2 or 3, you stop. Would you still be considered an alcoholic? Is it something that you should acknowledge, or is it just this is just the yellow light?
Question.
This is a warning.
So the way that the criteria reads, it's that you have to have met X number of these criteria within the last 12 months.
Right.
Okay.
Okay. So if you go 12 months without essentially meeting the criteria, we would either define you as in remission or not. Or not.
Yeah,
Or
sure.
not. Yeah.
Sure. Okay. So then what's the next step? 2 to 3 is mild.
4 to 5 is moderate.
And then severe is
5
anything
is
like
above that,
6
yeah.
or more is severe.
Mild, moderate.
And then severe.
See, in my mind, depending on which one on this list you hit, it would. Some of these are
Make a
definitely
difference.
more scary than others, right?
Right.
So if this was affecting your problems in personal life, despite negative consequences and medical issues, in my mind, even though you only hit 3, that sounds like full-blown alcoholism.
Yeah, and I mean, I think that you can certainly have a conversation with someone, and I do, about the ways in which they can reduce their drinking versus cutting it out entirely. And that's a conversation that needs to take place, not just...
So not cold turkey, but more control.
It sort of depends on the individual. I mean, if we're talking about someone that has liver problems, extensive liver problems, and we know alcohol is processed by the liver, then I would say, well, this is really damaging, potentially damaging to your health. And so you really want to not cut down, you want to abstain. Well, whereas if someone is having problems perhaps in their marriage or at work as a result of it, I might say, well, for you, perhaps cutting down is a place to start. And then we observe how this goes. And if it continues despite your reduction, then our next step might be abstinence after that.
Sure.
And even for the Food and Drug Administration, for them to approve a new medication for alcohol use disorder, they don't require abstinence. They simply require a reduction in heavy drinking days.
They require improvement.
Yeah.
Right.
Because
market improvement.
It's better for you.
Okay. So, and
reduced harm.
Right. Going back to your own personal feelings, do you abstain? You just don't want to mess with it, or do you? I say this coming from a religious background. There's 2 prevailing thought patterns with people who don't drink. There are people who just choose not to drink, and they don't really care if others drink. They don't see anything wrong with it. They just choose not to partake. And then there are those who preach against it entirely. Are you anti-drinking, or you just don't want to mess with it?
No, I'm not anti-drinking. And I think that the vast majority of people, in our country do not drink. I mean, we only have about 43%.
That's small?
Yeah. I mean, for about 43% of Americans are current users of alcohol. So I know that sometimes our perception is that everyone drinks, but the reality is that there are lots of people who don't drink for a lot of different reasons. For the same reason that there are a lot of people who drink for a lot of different reasons. I think our conversation really needs to be not just about the actual consumption of alcohol, but the reasons why people do it. It's like it's like with everything.
Right.
Sure. So so what have you guys seen? Well, actually, let's back up. I want to talk about the study again. When I had Googled you guys to try to find a great alcohol study, I did see like the I guess not the application, but kind of like the posted of this study. You guys were looking for certain types of people to do certain types of things. Can you kind of walk us through what you guys were looking for this study?
Yeah, so I imagine you saw the ad. Yeah. And there's two different ads. One is targeted towards veterans who have PTSD, who are drinking heavily.
Sure.
PTSD and alcohol use goes hand in hand. And even in the military, whiskey's just dated back since the Revolutionary War.
Sure.
I'm sure you guys know that and covered that before. But
my festival specifically benefits veterans, and the particular charity that we use at our whiskey festival. That didn't make sense, did it? The particular veterans charity we use is Warriors for Freedom, and it's specifically to help normalize their life outside of once they come back, and camaraderie, going out, fishing tournaments, kind of normal, getting back into a normal lifestyle pattern, that instead of being held up in your home drinking alone.
Yeah. And so, the one ad is targeted towards those veterans who are struggling with their alcohol use. And by and large, I imagine most of them are using it to self-medicate. There aren't overwhelmingly effective treatments for PTSD. There are a few approved medications, and certainly like cognitive behavioral therapies are also beneficial, but they don't help everybody.
Sure.
And so a lot of veterans, and there's also a stigma associated with mental health and receiving any sort of counseling.
Well, yeah, and on top of that, it's kind of compounded with veterans because there are some studies being released in regards to like drug MDMA giving veterans either marijuana or ecstasy to kind of cope with PTSD, and that's a double stigma, right? So yes, there's not a lot there for them,
right? And so that's why we're trying this other drug that's already approved for seizures, because that class of medication seems to help some people reduce their alcohol intake.
Sure. So you're, and I say that, and I won't name the name of. Well, I can name the name of it, but there is a drug, Zoloft, that's antidepressant, that I noticed earlier this year. There was a new drug being marketed for a certain function. I really don't want to say this. I saw this. I'll say it anyways. This is a professional discussion, but it's important. But the drug was being marketed to prevent premature release.
Premature ejaculation.
Yeah. Okay. And my face feels hot. And the drug was being promoted as like a cure, and they were listing the drug name, which I forget the name. I have it written down. Not that I had it written down because it was sorry,
this just took an interesting turn.
It took an interesting turn. I wrote it down because I was so shocked that it's been marketed for years under Zoloft.
Sertraline,
yeah.
So sertraline is,
I thought it was sertraline or sertraline.
Sertraline is Zoloft, but when
it came out, it was being marketed as a side effect that you might have trouble with this.
Absolutely, and urologists actually prescribe it for premature ejaculation.
And at some point, someone's like, "Oh, we can make money off this by marketing this side effect." So it kind of made me realize that how drugs are developed. You create a drug, which I think that's how Viagra was developed. Viagra was originally developed as a heart medication, and they were like, "Hey, this side effect could make us very rich," and
it did.
And it did. So that's what you guys are doing. You're trying to test an intentional use on the side effect of this drug as a cure for
but not to make money.
Sure. No. But even if you did, there wouldn't. Listen, there are lots of things that we as humans have stumbled into innovations that have changed the world, right?
Yeah.
I mean, penicillin is a perfect example.
Right.
It's not. There's nothing inherently wrong with making money, but it's so fascinating to see how we accidentally innovate all the time.
Yeah. Well, I mean, once these medications have been given to hundreds of thousands of people, you're going to develop this very clear side effect profile, and you can then capitalize on it like you've just described. So
sure, it's a funny aspect of the conversation, but I am endlessly fascinated with how we healthcare, how we cure things, right? So my wife, and I'm going to say this, but don't let it paint a stereotype. But her family's big into the essential oils and like the holistic.
Yeah.
But we still, in a heartbeat, the moment my throat hurts, I'm taking an antibiotic, right? So it's endlessly fascinating how these accidental things happen, and how long has that drug been out, and then all of a sudden you guys have decided to mainline on it, like to focus.
Yeah, zonisamide.
I don't even remember.
Yeah, I don't know. It's been decades.
And you guys have finally let's see if we can't use it for this other purpose.
Well, they stumbled upon this particular purpose with a similar drug in the same class, topiramate. And so then it was like, well, if this anti-epileptic drug has this effect, then why wouldn't other ones within the same class? And so, because topiramate has a bunch of side effects that people don't like and so won't take it. Zonisamide doesn't seem to have all those side effects, and
it might do the same thing.
It might have the same, or it might be better.
How long is the study going for?
Overall, for like a person who enrolls.
So, like, if you enroll, first of all, how many people are you bringing in for the study?
60.
Okay, so you bring in 60 veterans,
and they would be on the study for 5 weeks. They'd be treated for 5 weeks. They would either receive the medication or a placebo, sugar pill, sham pill.
Sure.
And they'd visit us twice a week for those 5 weeks, and we would give them medication, see how they're doing.
Is it a questionnaire, though? Is there a chance they might be lying to you about their consumption?
Absolutely. Yes. And a lot of the alcohol research is based on self-reports. And so the only way we know what we do is every time they walk in the door, we use a breathalyzer and we get their blood alcohol content. Sure. So we know right there if they're intoxicated. But beyond that, we also use a biomarker. We take a blood sample, and there is a particular molecule in it that we can look at, and it gives you a sense of binge drinking over the past month.
Oh, really?
And so we can use that to corroborate the self-report.
Sure.
But yeah, much of it is based on self-report. But at the same time, these people are seeking treatment. They want to reduce their alcohol use.
Of course.
And so there's no advantage to lying to the study coordinators or anybody about what they're actually doing, because then we don't know how they're doing. We don't know if we're helping them. We don't know how to adjust things.
Yeah, I don't know how much money goes into or how much money is needed in a study like this, and I don't know how expensive these items are, but I know there's another show I watch called the Joe Rogan show, right? And they did Sober October, and they made these guys wear these ankle bracelets that actually measure blood alcohol content. They wear it 24/7 like an ankle bracelet.
Mm-hmm. Wow, yeah.
And if they drink anything, it picks it up through the skin.
Sure.
Yep. So
we're not that sophisticated.
Sure. Well, so, and how long is it going to go for? Overall, you said 5 weeks, but then what's the overall? That's phase 1?
So that's the phase 2 study. And so the other study is just enrolling alcohol experienced individuals like yourself. If you'd like to sign up, give me a call.
What's it pay? How much can I drink? Depending on which question they ask first, is that a key indicator if they're like if they say how much can I drink?
Yeah, well, so and those certainly we have people calling who are interested in knowing how much they're going to drink, how much money they get paid.
Sure.
The reality is most people are looking for the payout, which is perfperfectly fine. We understand
that. Yeah.
But
how expensive booze is nowadays.
that study enrolls non-veterans or civilians as well as veterans who just use alcohol on occasion or are experienced. They don't necessarily have to meet alcohol use disorder criteria.
Sure.
But if they do, that's okay. What we don't want is for people to experience any withdrawal when they're walking in the door, because this can be a very serious situation.
Sure.
And we certainly don't want to cause any further problems by giving them an experimental drug that's only been in a few hundred people.
Of course.
And giving them alcohol on top of that.
Yeah.
And so that study, we bring people in, they stay with us in the hospital for a week, and we give them alcohol the first day they're there. We have them fill out a bunch of questionnaires. We have them do some cognitive tasks on a computer. we have them do the field sobriety test. You walk a straight line. And then we start treating them with the medication for the next 5 days. And at the end of that 5 days, we give them alcohol again. And we have them do all the same tests. And so now we just want to compare, pre and post and see. Right. And if nothing bad happens, everything looks the same pre and post, then that drug will then be tested in veterans who have PTSD and alcohol use disorder.
So they're kind of like the more kind of less worrisome group of people.
Yeah.
Than before you get to the ones that really
That's
need
right.
it.
That's right.
Wow.
I think it's really important to add, and I'm going to take over for just a quick second, because I think some of the listeners might have an issue with, a scientific study where we expose people to alcohol. And, we've had lots of conversations about the ethics of that. So I'm just like, if you can give your spiel to the listeners about that.
People have questioned the ethics of basically giving the people the disease not giving it to them, but you're giving them the illness in order to,
or at least exposing people to alcohol who might have a problematic relationship to it.
Yeah. So, whenever we screen for that early phase study, it's always looking for individuals who are not having problems with alcohol, who are not seeking treatment to stop using.
Okay.
And so that's the alcohol experienced as my sort of global catch term I use, I think.
But basically a non-issue, but someone who does drink.
That's right. Somebody who's not really concerned about cutting down their consumption or seeking treatment is really the key words that we use. And I'm trying to think of a better to describe
putting them
that,
into two camps.
That's right. Yeah. And so the zanisamide study, it's veterans who have an issue, and we think it's
they're more like the control group almost.
No, different studies all the time.
Not the veterans, but like the people who don't have an issue. They're more the guinea pigs.
Okay,
sure.
Because that's probably not the best word to use, but that study is using a compound that's only been in a few hundred people. And so we don't know how it's going to affect some people.
Sure.
Just about every medication out there kills people.
Yeah.
Tylenol. Probably shouldn't use that word either, but
Kill
the fact,
or Tylenol?
Huh?
Kill or Tylenol?
Tylenol. Any brand name, I imagine, is probably not a good thing. And so, there is that potential for a negative effect of the drug alone.
Sure.
And so that's why the people in the early phase study are more of the guinea pigs, so to speak, where we just want to make sure that in general, we aren't going to see this interaction between alcohol and the drug that is going to cause very severe problems for people.
Sure.
I think you really just want to focus on safety.
Yeah.
And how safe is the use of this compound, this medication in people who also happen to drink.
Thank you.
Right.
The word
right.
safety.
No, I get what you're saying.
Definitely what I
was. Versus treatment seeking, which is what we were sort of talking about with the second study, people that have PTSD and alcohol use disorder, and they are seeking some sort of treatment for that. And the medication zonisamide is the way that we're trying to do that.
It makes perfect sense. I mean, if let's just say 10% have a heart attack, well, you don't want to find that out with at this stage.
It wouldn't even get that far.
Right. I'm just giving a drastic example.
Right.
Okay. So if you're going to look for any kind of red flags, you'd rather it be in a more stable group than
much smaller sample of people that we have better control over.
Right.
And that's why we bring them in the hospital, so we know what they're eating and drinking every day. And there's, it's a hospital, so there's medical staff there 24/7. And if there's an emergency, they will go to the ER.
Right there. So let me kind of run some ideas by you guys as far as in terms of concern. So we've got the 11 key indicators. Is it so in this industry in particular, there's a lot of people who for work drink every day, right? We're not talking getting drunk every day. We're talking they go, a lot of the people in the bourbon industry or the whiskey industry are treated almost like celebrities. And when they fly them in town, let's say we've got someone famous in the bourbon world who flies into town, he's here for 3 days. They put him to work. He goes to a class with a distributor at 8 a.m. or 10 a.m. He's got an interview with me at 3, and it's just like boom, 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 boom. Do you guys... is there necessarily a concern with anyone who drinks every day, or is it more like the amount that they do within those sessions?
I would say it's more about how it affects them and the way they interact with everything else in the world.
Sure. So they could theoretically, as long as they're totally fine, because the whole functioning alcoholic thing's a bit murky.
Mm-hmm.
I've always perceived it as, I see it used a lot when people want to say, if you drink every day, even if your life's great, even if it's not drinking that much, you're a functioning alcoholic. And that seems like a catch-all blanket statement.
Well, I think that what we are really trying to talk about here is risk, and the National Institute of Alcoholism and Alcohol Abuse, NIAAA, has a set of guidelines about the amount that someone can drink in a day or on a week. And
I've seen the week thing, especially in the UK. They're very big on
so typically
units
we
per
say
week.
for anybody, any female that drinks over 4 drinks, any male that drinks over five drinks or more in a sitting, that is what we consider a heavy episode of alcohol consumption or a binge. And
so when you go to a night, like to a sports bar.
In a week, 14 drinks for a man, 7 drinks for a woman in a week.
Wait. Didn't you just say in a day it's 4 for a man and 3 for a woman?
Think of it this way. So say you have
5 for a man, 4 for a woman.
Right.
5 for a man. So say a guy drinks 4 drinks Friday night, Saturday night, Sunday night each. That's 12 drinks.
Jeez.
That's still under 14 for the week.
Sure.
And it doesn't sort of fall into the risk category.
Sure.
Yeah.
But if you have a 6-pack Friday night, Saturday night, Sunday night, you are now over 18 and you're over your 5.
Sure. Okay. And so if a woman, let's back that up, because the example you gave was 14 and 7, right?
Yeah. So 7 drinks
if
in a week for a woman,
if a woman does 4, that's 12.
Yeah, that's we would call that at-risk drinking.
What if it was 3, that's still 9.
At-risk drinking.
Really?
Yeah.
Even though she's not binge drinking any of those days.
Right.
That's correct. Yeah.
Interesting.
Yeah.
And so and again, having being like falling into the category of at-risk drinking does not necessarily mean that you carry a diagnosis of alcohol use disorder.
But that's definitely flirting with the devil.
But it just means that you are potentially at risk for going on to develop alcohol-related problems or perhaps other medical complications as a result of your alcohol consumption.
Yeah.
Okay. And what do you consider a session? Because like I mentioned yesterday, if I had one drink that I sipped on while filming for 4 hours, and then another drink at lunch, and maybe a gin and tonic for dinner. Like, you get what I'm saying? Like, you say a single session. What if it's an all day affair?
So we were talking about 2 hours before, but again, this is where the conversation with the person really comes into play, I think.
Sure.
Because if you have someone who, has an eye opener, so they may drink first thing in the morning as soon as they get out of bed, and then perhaps they go
eye opener, breakfast beer, tomato.
And then they go through their day and they have a couple drinks later. Perhaps you don't necessarily count all of that together.
Sure.
But I do think that the eye opener might fall into a different category.
Oh, sure.
Right.
Yeah. Like people, I always thought it was weird when people smoked first thing in the morning. You get up and you have a cigarette.
That's a huge sign of having a problem. Nicotine use disorder is that you cannot resist that first cigarette. If you had to give one cigarette, which one? Giving up that first cigarette's the hardest thing for people to do. So,
wow. Well, I don't smoke cigarettes. Do you guys study tobacco use at all? I know I kind of saw a video on you that was kind of briefly discussed marijuana use studies. Are you still doing any of that stuff?
No, not at the moment. No.
Yeah, I think it was 2013 or something. It was a couple of years ago during that interview. The study that I had seen, or not the study I had seen, but I had recently been talking to someone about how I think it's going to be legal by 2020
in Texas.
In Texas, I think it'll be
optimistic. I think, but anyhow,
most people have said it's optimistic, and I think I may just miss it. I think 2021 might be a little bit more realistic. But I had made this bet 3 years ago. Because every state, it seems like every year there's a new state that's on this list.
Yeah, I think we're at 31 or 33.
That's just a ridiculous number. And which just goes to show you how we've evolved and how things have changed. I mean, in Houston, in the Heights, just a few years ago, they voted to make it a non-dry, and it was almost a unanimously no. And then now, like just a couple years later, it was almost unanimously yes. That everyone was like, yes, we should totally be allowed to have a beer in the Heights, right? And I just think it's fascinating that the way that we are perceiving our judgment of things, whether it's alcohol use or tobacco use, or we seem to be a bit more hesitant in jumping to conclusions, a little bit more trying to find the right place on the scale instead of just saying.
And it's interesting because I think as we have seen an increase in the number of people who are using cannabis for all kinds of reasons, we've also seen a kind of gradual reduction in the number of people who are being diagnosed with alcohol use disorder. And so, I don't.
You think they go hand in hand?
I think that people might be switching, actually.
Right.
Yeah. And
from drinking to smoking.
even the opiates, Do
you think that's a better switch?
And opiates as well.
Yeah.
Yes, off the opiates over to the marijuana.
Yeah.
Which I would definitely be willing to bet that's a better medication.
Yeah. Even if we're not talking marijuana, we're just talking the main psychoactive THC. Ingredient, THC, is really what is beneficial. And so, maybe marijuana is, but maybe it's one of the other 200 cannabinoids in the plant that nobody's studying.
Sure.
There's no doubt that cannabinoids have positive effects on pain. Maybe not positive. They help alleviate pain.
Sure.
But the ability to study it for those sort of indications has been stymied by the government for so long.
Oh, yeah.
And so that's why we are where we are
in like
now.
A blatant political way. Like everyone realizes and acknowledges that there's
Finally,
a clear medicinal studies that need to happen, and the red tape is what's driving everyone.
And I get it to a point. You're never going to walk into your doctor's office and they're going to say, "Hey, smoke this 2 times a day. Let me know how you're doing."
Sure,
that's not going to happen. But we can isolate the individual molecules. We can test them, but we still have hurdles to overcome in doing some of these things.
So, and you feel like it is a better switch to go from alcohol or opioids?
I think that it's a much more complicated and nuanced question, and here's why. I do think that for some people, certainly the switch is absolutely better for them in the short and long term, just because of the really devastating impact that opioids can have, like we were talking about the switch from opioids.
Or the immediate devastation that alcohol can have.
So the fact that people have overdose deaths, and I mean, like these are, so, yes, people can sort of overdose on cannabis. I think it's probably because they're smoking synthetics as well, which is a whole other conversation. Yes. And that might be why we're seeing more people coming into our emergency rooms as a result of synthetic cannabinoid use. But generally speaking, I think that the switch over from opioids, because of the danger that's associated with, particularly related to opioid overdose and overdose deaths, is preferable.
Yeah, you can overdose on alcohol. You can overdose on opioids. It's nearly impossible to smoke enough pot to overdose.
Yeah, I think I saw somewhere once it was like you'd have to smoke like 1,500 pounds of it in one sitting or something. It's some ridiculous amount some crazy amount of milligram or that it would just be not likely to happen even on one of those extra fun special nights, right?
Unless, the issue with marijuana comes up whenever you have children in the house. They get a hold of your edibles.
Same thing with alcohol.
And those things are highly concentrated, right? It's just like we're talking maybe fentanyl versus oxycodone, right? It's a huge difference. Yeah. And that's where the danger comes in.
Fentanyl, is that what killed Michael Jackson?
Propofol.
But
and fentanyl is involved in,
fentanyl is that patch, right? It's like a super mega.
Well, now
100 times more potent than morphine.
Yeah. Fentanyl is now being created in these super labs in Mexico and being infused into counterfeit pills and coming over and flooding our.
I saw a video not too long ago of a cop that accidentally was exposed to fentanyl. I think. And he had an immediate reaction, and it's horrifying. I don't know if this joke is going to make you pass judgment on me, but I think I'd rather switch with this painkiller than I'd rather have a glass of whiskey than screw with some crazy super drug that's.
Yeah, and then getting back to the whole marijuana thing, it is an issue for some people in particular, especially veterans, because if they test positive for something like marijuana, then they have huge issues with their benefits. And
oh, really?
Yeah,
I didn't know that.
Yeah. I mean, so I think that that's true for a lot of different people. We have a lot of folks out there who are unemployed, and they may spend a lot of time smoking at home.
Sure.
And then they go in and they can't pee clean for a job. And so it can contribute to, unemployment, underemployment, and those sorts of things as well.
I'll never forget when I had a marijuana study here, the first guy who came in, he was the first guy came in for any of my studies, so I'll always remember him. He was a hulking man. He was 300 and some odd pounds, and he was intimidating. He was crying in front of me because he couldn't quit smoking pot, so he couldn't move out of the bus on his mom's property that he's been in since he was a kid. That guy had a very serious problem.
He was super addicted to pot.
Yeah.
I know, and I've watched many a discussion on this subject, and people often falsely say that, marijuana is not addicting, but any habit can be addicting. Any habit can be addicting.
Mm-hmm.
And depending on your chemical makeup and your situation, where you are in your brain development, it could be a real problem.
Yeah.
That sounds horrifying.
And so this is one of those times when the unsuccessful effort to cut down or quit comes in, and becomes the cardinal symptom for someone when they're trying to not smoke pot and get ahead in their life, and they find that they are unable to do so because they've got a urine drug screen that's positive for cannabis.
Well, the fact that he was breaking down crying and acknowledging that
horrific
it's a huge,
for some people,
right? And those are the people who are seeking treatment very clearly.
What's his name? I'm just kidding.
I'll give you a social.
So when's the study over? Like when can we see results? Like what if this turns out to be a huge success?
Well, so can
I come on your boat?
This is what. You can come on my paddle boat. This is a phase 2 study, and so the next would be a phase 3 study, which would enroll a lot more people.
It would expand your test group.
Yes. Yeah. And so
if we go from 60 veterans to, what are we talking, like a couple hundred?
Yes.
Okay.
And it would have to be repeated a few times, and they get enough data together, then yes, it could eventually be approved as treatment.
So let's say perfect case scenario. Are we talking before you could see this on the market being advertised as or used? Would you say 2 years?
No, I would say
conservatively.
Best case, maybe 6 to 10.
So it's a long-term thing.
Yeah, all of these are. All medication development takes a very long time.
Well, it's a huge risk putting anything out there.
Well, and that's why a lot of pharmaceutical companies are not investing in substance use disorder treatments because it is a huge risk, and there is the stigma, and there is the investment, and so there is just not much to gain for them. They want the Viagras.
Sure.
Yeah. I mean, as it stands right now, there are only 3 FDA-approved medications for the treatment of alcohol use disorder.
Right. One of them makes you severely sick if you do drink.
You've probably heard of Antabuse, disulfiram.
So no one takes it.
No, but I have heard of that. Where there's one that it'll make you throw up if you
Antabuse.
Yeah.
Or
disulfiram.
Right.
So is that similar in like methadone? Because I'll tell you, and let me explain what I mean when I say similar. I mean, I explained to a few people, you guys are coming on today and trying to explain what the conversation was and what you're trying to do.
Mm-hmm.
And 2 different people, 2 different times, I said they're trying to find a drug that can help treat this, and they were like, "Oh, like methadone," and I'm like, "Well, I don't know."
Yeah, so methadone is like a substitution for opioid. It's an opioid, right? And so it can be used for pain.
So it's not so much a substitution you're looking for, but more of a, like I said earlier, of a suppressant of cravings.
So when I think about opioid treatments, there are a couple of different ways to go. There's for opioid use disorder, you have opioid replacement therapy, which is the methadone or buprenorphine, which is also known as Suboxone or Subutex. And then there's opioid blockers, which is naltrexone, which can be given in a shot in your arm,
and then you don't feel the effects of the opioids.
So if somebody tries to take heroin on top of naltrexone, they don't get a high from it.
They don't really?
Get euphoria from it.
I didn't know that.
This is really not that.
So they just get through. Is that the idea? Is that you take it, and then if they decide to do it and it doesn't work,
they'd have to spend so much money on the heroin or whatever the illicit opioid is to get a high. That should be turn enough either to stop taking the medication or to say I'm not buying anymore.
Will that get you through withdrawals?
So you can't give naltrexone that shot until after the person is through withdrawal.
Okay.
So
it will induce.
Yeah, absolutely.
Withdrawals.
Okay.
So if you give it to someone who just took heroin yesterday, they will go into withdrawal and then they'll want to fight you when they're done.
Sure.
When they're done going through withdrawal, they'll want to.
What other studies have you guys worked on besides alcohol and marijuana?
Cocaine, methamphetamine. Yeah.
Man, you guys had a lot of fun in college, or what made you want to go here? Because you guys are both.
I can tell you for myself. I was in private grade school, Catholic grade schools, and I switched to public in 9th grade, 10th grade.
Oh, that's a cold bucket of water.
Absolutely. I knew about drugs but didn't really have any near me in the Catholic schools.
Sure.
And then all of a sudden they're everywhere.
They're everywhere.
And Nancy Reagan's on the TV and there's the frying pan.
Dare,
this
right?
is your
Dare.
brain on drugs.
Yeah.
You know, I'm older, so I don't know if you know that
Well,
reference,
my kid's older than yours.
and just say no.
15-year-old kids, I'm worried about every day.
Right.
What they're, you know.
And it was the whole just say no thing that really bothered me, because I had friends in one group who were using drugs and you could tell they were going down the wrong path.
Sure.
I had other friends who would, on the weekends,
Special occasions,
party, whatever.
Right. And they're fine.
They're perfectly fine and successful. And so it just didn't make sense to me that for everybody, this is your brain on drugs and just say no. I needed to have a better understanding, a scientific understanding.
That's fantastic.
That's why I
respect
got into
that
this.
incredibly.
And it was really marijuana that was, the most prominent drug when I was in high school.
Still is, right?
That's why I, focused on cannabinoids for so long. But, a lot of people who use marijuana do use other drugs.
That's right.
I grew up in such I grew up Pentecostal. It's anti-everything. Teetotalism to the extreme, right?
Yeah.
I felt the same way. My mom was the black sheep in her family, but she didn't drink. She smoked, and she worked at a bar. But she couldn't have been more functioning and normal and happy.
Yeah.
But just because she wasn't the super religious, it was like she was the black sheep. And then everyone around me that I went to church with growing up turned out crazy. They went down right around 17, 18, 19.
Yeah.
Well, the Pentecostals.
It was a mad dash for hell,
freedom.
Right?
Yeah, I would imagine. You want to experience things that you've been so...
No shade against the Pentecostals.
Yeah, no, I'll throw it. I'm from there. No, but I do respect those who just seem to have a more reasonable, logical approach to things instead of an extreme aversion.
Yeah.
Because the extreme aversion, I think, encourages the opposite. Like, what do you call it? A rubber band effect, where when you tell your kids no, and then the moment they can, they will, right? So,
but I think what we're talking about really is that people need to reflect on the impact of these things on their lives in a really honest way.
Sure.
And sometimes I can deceive myself all I want to about my use of my phone, for example. Like, I know I should not check my email at 4 a.m. at night, right? Like, my addiction to my device is
there.
Is present.
Sure. But that shows personal growth. Right. You're able to acknowledge that.
I appreciate you for saying that. Yeah. But I have unsuccessful efforts to cut down my use of my phone. I'm in my car, I do fairly well, but like at dinner, I'm on my phone.
Sure.
It's so, I think what we're trying to encourage people to do is just to honestly look at your relationship to this thing. And if you don't know, if you have a question, then talk to someone about that. Yeah. Talk to a professional about that. Yeah. If you have the question, even, and the answer might be, well, try to make this small change. Maybe it's, and you just try to bring it down so that you're in the level where you're no longer drinking at risk. That could be enough in and of itself. For
but
some
we all
folks.
have to manage ourselves, right?
Yeah.
So that the idea that, I know that if I'm hitting 240, I need to lay off the sugar or the fast food, or it's all about acknowledging when things start to get a little bit out of that line and bring it back to mid-level.
Recognizing it within yourself. Yeah. I think a lot of people have a hard time with that.
Yeah. Yeah. Not me though, even though I'm the one with 3 bottles of whiskey in front of them. This flew by, and I would absolutely love, if you guys would come back on, not right off, not tomorrow, but I would love to get you guys back in here. I think this is going to be a very well received episode, and I have so much more I want to talk to you about.
Yeah, so sure. See how it goes.
Yeah,
if it's well received.
Oh, it'll be very well received. In fact, I had a few people. So there are lots of bourbon alcohol podcasts. No one's really addressing this side of it. It's more like, hey, here's the history behind this American spirit and blah, blah. No one's really discussing the risk side and if anyone should be discussing it, it should be us, right? If we're the hobbyists, it's something you should be concerned about.
At least aware of.
So what about when in your community, we're going to go over, I'm sorry, you can cut it out if you want to, but what about in your community when you all see someone that you think is overdoing it? I mean, how is that?
There is someone that comes to mind, and there are conversations that are had. But
with the individual, or is it like
the person I'm thinking of,
or she's a mess?
The person I'm thinking of, I've said he's a mess. People have said he's a mess. I've said he's like the lovable, rapscallion. If you ever seen the show Shameless,
yes,
Frank Gallagher. he's a very good, very generous man, also a veteran. There's a history there. But for the most part, his life is fairly together. But sometimes it gets a little bit out of hand. But beyond having these conversations and trying to talk to them, it's hard to go much further than that. And at some point, you can only either laugh about it or not talk to the person anymore. You know what I mean?
Yeah.
So, and when I say laugh at it, I mean, don't laugh at their plight, but they're just being this person, right? So as long as they're not drunk driving or at risk and hurting anybody, and at some point there's only so much you can do that it becomes kind of you just love them, right? It's not hard to love somebody, and when you see them, you hug them, and you know what I mean? It's hard. You don't really know what to do at a certain point.
Yeah, I mean, that's what I was sort of asking, because I would imagine that if you are going to lots of these activities and you all develop a real sense of community and friendship, with
really
folks,
great community here.
And so you are concerned about this person at the same time that you are
enjoying their company.
I'm going to throw shade at you guys a little bit, because being doctors, you can give them the truth, and then they leave. Right, and they leave the room. Right, whether they take it or they not, your part's done.
Right.
It's a little different when you are friends with the people and see them every day.
Of course.
All right. Well, I thoroughly enjoyed this. You guys are fantastic. I'm really very happy with this. So thank you so much for coming on the show. I appreciate it, Daryl.
Thanks for having us,
Chris. I appreciate it, guys. And cheers.